Great. Well, good evening, everybody, and a warm welcome to the Alliance for International Medical Action, or ALIMA, and ALIMA USA, and our webinar on the front line of COVID-19 in Africa. My name is Elia. I'm the president of the board of ALIMA USA. ALIMA USA is the American section, the US section of ALIMA. We are based here in New York, supporting the work of ALIMA in Dakar and our partner countries. I wanted to mention our Board Plus and thank them for their support of this event. They're providing wonderful operational and strategic support to us at ALIMA USA here. As you can see at the bottom of your screen, there's a Q&A function, and you can submit questions, so please feel free to ask any question throughout the webinar, and we will try to get them when we can. The webinar is also streaming on Facebook Live, and we will be sharing a recording with everybody who has registered. This webinar is a part of ALIMA USA, ALIMA's Oxygen for Africa campaign. It is designed to raise awareness and funds to provide much needed oxygen concentrators for patients in Africa who are impacted by the COVID-19 emergency. Please go to oxygenforafrica.org if you're interested in more information. Also, just so you all know, in support of the crisis, Tuesday, May 5th has been declared Giving Tuesday. It is a day to mobilize support for the fight against COVID-19. We hope you consider ALIMA as a part of your giving on that day, and please check our website at alimausa.org and look for the Oxygen for Africa campaign. Please also consider sharing on your social media this event and related material. I am very pleased to welcome two of ALIMA's team members who are really on the front line of fighting COVID-19 in Africa. They are leading ALIMA's work on many fronts and in recent weeks on the COVID-19 fight. Nicolas Mouli is joining us from Dakar in Senegal. He's ALIMA's Emergency Response Coordinator. He's in charge of emergency programs and country opening. Nicolas joined ALIMA's team in Guinea in 2014 during the Ebola epidemic. After several missions in Nigeria, South Sudan, and the DRC, he took over as Emergency Response Coordinator in October of last year, and now he heads our COVID-19 intervention. Dr. Susan Shepard is ALIMA's Director of Operational Research and Medical Advisor. She manages the development of ALIMA's research programs, including new strategies for preventing and treating childhood malnutrition and the development and treatment of vaccine-treatable diseases, including Ebola. She's a pediatrician and has been working with ALIMA since 2014. Thank you very much, both of you, for joining us and sharing with us some of your experiences from ALIMA in Africa. For those of you who are less familiar with ALIMA, let me just say a few words before we jump into the conversation about COVID-19. ALIMA is a humanitarian medical organization committed to providing quality healthcare to the most vulnerable people, children, women, refugees, internally displaced people in high mortality areas affected by emergency. ALIMA really works in some of the hardest to reach places on the planet, and we are really honored to be supporting their work. ALIMA's approach is based on partnership, both with national governments and with national humanitarian actors. ALIMA believes in working together and in finding innovative solutions for local context to really help the local populations. ALIMA is committed to improving emergency medical aid and to transform the humanitarian medicine by conducting research and innovation to scale the impact of humanitarian actions. You may be familiar with some of their work, including the Cube, which was instrumental in transforming the way we treat Ebola on the continent. In 10 years, ALIMA has treated more than 5 million patients in 14 countries and has launched 30 research projects on malnutrition, malaria, Ebola, and Lassa fever. ALIMA works on treatment of infectious disease, emergency response, and comprehensive maternal and child health. I wanted to start perhaps by going with you, Nico, and asking you just at a high level, maybe you can describe for viewers the situation on the continent right now regarding COVID. What is predicted to happen in the next few months? Where are we looking at the epidemic moving? I think viewers are very familiar with what's going on in Europe and the US, but there really hasn't been a lot of press about what is happening in Africa, and I think we're all very concerned about it. So we would love to get your initial updates to get started.
Okay, thank you, Ilya, and good evening to everyone. So to summarize shortly on what is the situation in Africa, we had as of yesterday evening about 33,000 confirmed cases, which is about 10,000 more than last week and 20,000 more than the week before, and about 1,470 death cases. The first, let's say the first confirmed cases in Africa was around the beginning of March with the Nigeria, I mean sub-Saharan Africa, in Nigeria, South Africa, and Senegal, and we see since then that the cases, the number of new confirmed cases are increasing slower than in Europe, but we are coming to the phase where the number of new cases are going to double every 6 days, then 5 days, and then we will see probably the same trend than in Europe. In the countries where ALIMA is working, in the 12 countries in Africa, we have about 7,000 cases, and the Cameroon, Guinea, and Nigeria are the most affected. We see a little different trend than in Europe because the number of testing is more limited. So instead of having the beginning of a peak after 3 or 4 weeks after the new confirmed cases, it's more about 6 to 7 weeks, and we expect to arrive in this situation maybe in the middle of May, end of May, to reach a peak by the beginning of July. So yeah, that's it briefly for Africa. I don't know if you want me to go for more specific ALIMA countries.
Maybe we could get to that, but maybe before we head there, Susan, I'd love to hear from you. When we think about the treatment and the plan for attacking COVID in Africa, is it different in any way from the way we think about it in other regions?
Good evening, everybody, and thank you very much for joining in the webinar. Hi, Ilya. No, our response, I think, in our projects in ALIMA is based on the same tenets as anywhere. You know, the first thing we do is think about protecting our personnel, the first and foremost. And so we have been spending a lot of time on training and getting supplies to make sure that our staff are protected and that our regular projects can continue to function. Then second of all, we think about how to identify cases, how to identify so that you can isolate, so that you can minimize transmission. And then thirdly, of course, how do you treat? How do you treat the people who are infected, and how do you, maximize the chances that they recover, which is, of course, where it goes directly to how do we identify those who need oxygen and make sure that they can get oxygen and support them as their body recovers, as they recover.
To that point, can you speak a little bit, I mean, we're talking about oxygen for Africa. Can you talk a little bit about oxygen concentrated, what role they play in treatment and why they're so important?
Yeah, well, in Europe and North America, we tend to take medical oxygen for granted. And of course, that's, so we're up against a big logistical challenge here, because most of the hospitals where we work are district hospitals where they have absolutely no access to medical oxygen. And so we only can provide what we can bring in ourselves. And the way that we do it is through something called an oxygen concentrator. And it's you might have seen them if anybody has a family member or grandparent maybe who needed extra oxygen at home. You can be home on supplemental oxygen, and these are just devices that are able to basically distill the oxygen that's in the air and concentrate it so that you can deliver higher flows or higher concentrations of oxygen in the inspired air. So that's what these devices are. And they, can provide 10 liters, sometimes 15 liters of flow of oxygen. And in the particular case of COVID, I mean, this oxygen it's a medical treatment. It's something that you prescribe, like an antibiotic. And the main treatment for COVID disease is oxygen.
It reminds me a little bit actually in the days of Ebola. I was also involved in the response in 2014. There really was no treatment for Ebola. It was just a matter of caring for the patients as we see them through, right? And it sounds like in COVID-19, really the only thing you can provide is oxygen. Are there other things we can provide?
What we call supportive care. And so I think that, when anybody falls ill, we try to do everything we can to, manage their vital functions. And so if people are dehydrated, we rehydrate them. We can, check their blood chemistries and fix any abnormalities. If they're lacking oxygen, which is the cardinal feature of COVID pneumonia, we provide supplemental oxygen to try to accompany them through until their body's immune system can mount a response and fight off the infection. I mean, of course, at the time, and so this is, the initial response, and we're just like everybody else. We are participating also in developing trials to try to look at whether there are specific therapeutics that may actually increase the chances that people can recover. None of our trials are still in the protocol development phase. None is actually initiated yet. But we're hoping that by the mid to end of May that we'll be able to start including patients in trials in at least 2 countries.
Wonderful. Nico, do you want to talk a little bit about how ALIMA is positioned to be effective and partner in these countries, in the countries that we work in? And maybe you can also mention some of the countries specifically that ALIMA is active in, especially regarding the COVID-19 work.
Yeah, sure. Well, we actually started to work with the teaching hospital in Dakar, Senegal, before the beginning of the outbreak, thinking that we should be prepared for this. And then actually 2 weeks after we started the discussion, the first confirmed cases was there in Dakar, and we had to deploy a full emergency team to work with the hospital for extending the bed capacity and to strengthen the biosecurity measures, the prevention and control of infection, with the first objective to protect the health worker that would be managing the COVID cases, to avoid them to be contaminated, of course, and to be able to provide at the first days the treatment for the patients. And then actually it went very fast, because in 9 weeks, in 9 days, we had the new confirmed cases in Cameroon, then in Burkina Faso. And at the very beginning, we had this solicitation from the Ministry of Health to work with them, to collaborate with them, to be sure that we can have at least 1 or 2 hospitals that would be used for managing the COVID cases. So we had to scale up very quickly in Burkina Faso, where we are working in teaching hospital in Ouagadougou, the capital, and we're planning to have more than 300 beds to manage this the severe cases, as Susan just explained, and those who are gonna need oxygen. We also had to increase the capacity in Conakry, Guinea, where we're planning to have about 400 beds for severe cases. And we were just speaking with them 2 hours ago, and they were saying, okay, there is a very big increase of new confirmed cases, and they were already disseminating at about 390 confirmed cases at the hospital, and we're trying to find another building to have 200 beds more. So in Conakry, it's increasing very quickly. And we are also working in Nigeria and in Democratic Republic of Congo with the Ministry of Health to manage the confirmed cases. Among these, the first objective for all ALIMA, of course, is to be able to protect the health workers that are already working in our 12 countries of intervention, and to be able to provide them with protective individual equipment, to be sure that they will be able to continue to treat the children or the pregnant women that we are seeing all the year, and to avoid disrupting this healthcare services.
I hope everyone can see the chart on the screen right now. We're seeing relatively small numbers if you compare it to the kind of numbers that we are seeing in the US, in Europe, but very concerning trajectories. Can you talk a little bit about those numbers? How real are they? Tell us a little bit about the testing that is or isn't happening, and how big are we afraid that those numbers will get? Do we have any sense? Is it really an unknown?
Yeah, I can field that for you if you'd like, Nico.
Yeah, please.
Just as in many places in Europe, certainly here in the United States, testing is the major barrier. So you can't fight what you can't see. And we know that the cases that are being identified, they're grossly, what we're seeing is far less than what is really there. As you can imagine, in health systems that are not that strong to begin with, having all of a sudden influx of 500, 600, 700 tests a day that need to be run, dealing with backlogs and people waiting 4 or 5 days to get their test results, kind of the same sorts of things that we've heard here in the States. But unfortunately for people for example, in our program in Conakry, we got people sitting in the hospital waiting 4 or 5 days to get their test result. And that's, that's creating unhealthy crowding. It's really, I think even more so for Africa, this issue of point of care, rapid testing is going to be absolutely essential if we are ever going to get a good handle on this. We've got to be able to decentralize testing out from these, usually there's only 1 or 2 places in each country that can perform the tests, and to be able to give people an answer within minutes or an hour to determine whether they need to be isolated or not. These are all going to be keys to getting a good handle and providing people the kind of care that they need.
Thank you. Nico, can you talk maybe a little bit, you started to tell us about the hospital in Conakry. I think many of us are used to, by now, seeing pictures of hospitals in Italy and in New York. What does it look like in Conakry or in the DRC or in many of the countries that ALIMA is working on? Do we have the capacity? Do we have the beds? Do we have the ability to protect the health workers? Are we expecting the kind of volumes that we have seen in places like Italy and China and the US?
Well, the overall bed capacity is far less than we see in Europe or in the United States. I think we have like 20 times less beds for hospitalization and 50 times less doctor per population in West Africa. So if you can imagine, for example, I think in France, we reached about 10,000 resuscitation beds for all the country. And here in Senegal, which is one of the better country in the region, it's about like 20 or 30 resuscitation beds. So we are very far from the capacity that we should have. And again, it's different between the capital and the rural area. So here in the capital, in Dakar, in Conakry, or in Ouagadougou, there are teaching hospitals where we can work with, and they have medical doctors and nurses that we can train and collaborate together to provide this care. But if you go out of the capital, then there is nothing. The hospital, they don't have electricity. They barely have doctors and nurses. So even if we are going to bring the oxygen concentrator, then we're going to have also to bring all the power to make them work, which is also going to bring an issue of logistic, of supply, and all of this has to be taken in a context where probably we also have war or conflicts ongoing. So for example, in North Kivu, where there is still an Ebola outbreak ongoing and there is an armed conflict ongoing. Now you add the COVID cases there. So all this bring the challenges that we are trying to address. Now, if we look at more in Conakry or Ouagadougou, in Ouagadougou, for example, there were initially 34 beds to manage the confirmed cases, and we managed to extend up to 36 now, 36 beds. And to extend to 36 beds, we had to recruit more than 150 people in 1 week. It includes medical doctors and nurses and hygienists to make them come in the hospital, to provide them with all the protective equipment, and to equip the treatment units to be able to manage the COVID cases. So this is, let's say, the first step, because we have now, we have to scale up again to 2 times or 3 times what we are already doing. Yeah.
Yeah, and I can imagine. A quick reminder to anyone participating: please feel free to write down any questions, and we will get them as soon as we can. But a question on this: I think many of us have been to hospitals in Africa and have lived in Africa in a number of different places, and I have 2 concerns if I think back of my time there. One is, how do you do social distancing in Africa altogether? In many of the cities in Dakar or in Kinshasa or in Conakry, that must be very difficult. And then in the hospital itself, given the limited capacity we already have and the burden of disease of things like HIV and malaria, how are we handling the ongoing flow of demand? Are we seeing hospitals being emptied out to make room for COVID-19? Are we managing to treat COVID-19 patients alongside the regular ongoing demand that we're seeing, especially in area that ALIMA serves, like conflict area and high vulnerability area?
Susan, please go ahead.
I mean, this is as always, like I said, we have put in a lot of effort to try to maintain regular program activities. We all know that if we let our guard down, that, you know, a measles epidemic is virtually inevitable because vaccination rates will fall. It happened in the Ebola epidemic. It'll certainly happen here. Malaria, we treat hundreds of thousands of cases in ALIMA every year. And so strategies like the chemo prevention strategy is even more important this year than in other years to try to protect people. So this is why we're trying everything to keep regular programs going. We have, and obviously whenever an epidemic breaks out, people get afraid, and they, you know, and so in some places like in Bamako, where we've been building up a nutrition program, we started, you know, seeing, you know, people were, you know, frequentation of the system dropping off. I think that Nico may have mentioned that in Ouagadougou, yes, they basically co-opted a whole university hospital and emptied it out and transferred patients elsewhere so they could just have one very large COVID treatment center. So there are, I mean, a variety of strategies that people use, and that, you know, I think, you know, very much the same like what's been going on in New York. I mean, there were some COVID designated hospitals and other hospitals. I mean, the approach isn't the same. This isn't really different. The problem is the means that you have. It's, you know, like Nico said, we just have fewer doctors and fewer nurses. I mean, we have intensive care doctors. We just don't have the logistics that, you know, or the nurses that, you know, that actually make that, or what we are constitute what we think of when we have intensive care. So it's, you know, we're not far from being able to give, you know, the same quality care. It's just a matter of getting the logistics right. So I wanted to pick up something on when you mentioned social distancing. I don't think that there is actually, well, Nico, you can speak to this because you're actually in Dakar and you know, experiencing this on a daily basis. But, you know, you can, you know, wear masks and you know, organize yourself. I saw a photo of a market where people, you know, women were in their marketplace, you know, each spaced, you know, 2 meters apart. But what we can't, what is going to be very, very difficult for most of the communities where we work is to shut down, right? Because there's, you know, if you say COVID in French, COVID, they say Covid, which kind of rhymes. So there's already a rhyme that's circulating around called poche vide, empty pocket, right? And that's, you know, which brings me right back to the testing question, truthfully, because between you know, lockdown and testing, I mean, these are kind of two arms of a strategy. And if you can't really lock down your population because you just don't have the economic reserves to do so, then really the only other option you have is to just test everybody, is broad-based testing so that you can identify all those cases and get them isolated. So that's why, I mean, the more we progress through this, the more I'm convinced that testing, that you know, novel testing strategies are what are going to get us through this in sub-Saharan Africa at any rate.
Great. Thank you. We have a quick question from the audience. With respect to powering the oxygen concentrator, can you talk a little bit about that and how, just in general, how feasible, expensive, possible it is to get sufficient oxygen to these patients?
So one oxygen concentrator costs about €1,000, so about $1,100. I can't speak too much to the logistics of it. Did you say power? I mean, but one oxygen concentrator can deliver between 10 and 15 liters per minute of oxygen, which is generally sufficient to provide, to supplement most patients. We have other more sophisticated devices where you can couple two oxygen concentrators together and you can boost up, and you can even deliver what's called high flow oxygen, delivering up to 60 liters per minute. So with these, you know, standalone semi-portable oxygen concentrators, we think that we can, you know, provide the type of oxygen we need. We can also, I think, use them to drive ventilators if we actually do progress to providing more invasive towards a ventilatory support.
Great. Nicolas, can you talk a little bit about the kind of partners that ALIMA is partnering with in these countries and who we're working with specifically?
Yeah, the first partner is obviously all the Ministry of Health where we are working with. I mean, that's how we used to work in the countries of intervention, meaning that we are not going to set up something in parallel of the health system and without the Ministry of Health. The idea is really to collaborate together and to treat the patient together with the with the staff from the Ministry of Health and the staff that ALIMA would bring to be able to have enough people working there. Then obviously with the national NGOs that we are partnering with since about 10 years now. For example, in Ouagadougou, the head of the clinical case management for the whole national response is the president of SOS Médecins, which is an NGO that is part of the board of ALIMA. So we are working together on that. And of course, we are collaborating with the other medical organizations, so the World Health Organization, Médecins Sans Frontières, and the other. That's mainly all these people. I just forget the community and the population, of course, because that's why we are working for them, and we of course try to give them all the means to contribute to the response with us.
Fantastic, thank you. Excellent, thanks. We have another question. I just wanted to throw it out there. There has been a lot of controversy around malaria drugs here in the US, especially. And there's a question from the audience about malaria drugs being more prevalent in Africa and whether that has come up in any way, or are you seeing that as something that is a part of the treatment or part of the investigation, given ALIMA's experience and work on innovation and treatment?
Yes, I'm not surprised that this question has come up. So as you may know, hydroxychloroquine is just a version of chloroquine, a drug that was used widely for malaria treatment until about 20 years ago. So it's an inexpensive drug that is very, very, very familiar to most people living in sub-Saharan Africa. And with the arrival on the social media networks of the work done in Marseille that suggested that hydroxychloroquine in combination with azithromycin might accelerate viral clearance, it was immediately taken up. And so I have not seen a national protocol for COVID treatment that does not contain hydroxychloroquine plus azithromycin as standard of care. And so that is provided to, which I would say that which is certainly not ALIMA's position, because ALIMA's position would be that there's no evidence to suggest that patients who take hydroxychloroquine plus or minus azithromycin actually have an increased chance of survival or have a decreased chance of deterioration. And so the answer to that is we don't know. There are certainly significant side effects associated with these drugs, and they need to be managed carefully. So at this point, the way that, because working in partnership always requires a certain amount of negotiation, right? And so as long as it's in the national medical protocol, we don't oppose it, but we certainly certainly don't promote it. Ellie, we've lost your voice.
Oh, sorry about that. Can you talk a little bit about any challenges that we are seeing, either Susan or Nicola, in terms of supply chain or in terms of recruitment of health workers, any operational challenge that you're seeing on the ground to mounting this effort?
Well, you just mentioned the two biggest challenges we have regarding the supply chain. Of course, we are used to supply all the medical equipment and the drugs from European country or North America countries, and obviously all these countries keep the stock for themselves, and especially the very essential items such as the PPE and the oxygen concentrator. So that was the first difficulty, and we had to find other source of supply coming from countries that already passed the peak, so mainly from China or Asian countries. So that is a difficulty. We have to supply approximately 600 oxygen concentrator, and so far we could receive only 15 in Senegal. So we are waiting to receive big orders in the coming week, but it takes too long compared with what we are used to. The second challenge regarding the supply, of course, is the prices and the competition that we see all around the world regarding some items like the mask, for example. How are we going for medical NGO to be first compared with the US, for example? It's going to be difficult. So we have to supply approximately 1 million masks for all the countries, and we are still waiting for it. And I do not mention the prices. So for example, well, the prices of all units is increasing, of course, and even the prices for international transports. Before the COVID, it was about like for one, let's say for $1,000 of supply, we had to pay 300, and now we have to pay between 500 to 600 for $1,000 of supply. So this is very increasing every day. So that's a daily fight actually. And the second challenge is, of course, is regarding the human resources. So up to now we had to work and to do with local and national resources, which is good because they are in the front line and they are the first responders to this. But now we are since we are scaling up the beds capacity, we also have to bring more experimented human resources, medical, but also logistic and in terms of coordination that are used to manage this kind of outbreak. And we are facing, of course, the unavailability of them from European or North America countries because they are also working in their own country, and obviously the closure of borders that, I mean, we cannot move. We cannot move, so we have to find a solution to bring these first responders in the countries here, and then to make them work. We hope it's going to be easier, maybe in 10 or 15 days, and we are thinking having maybe about 100 international staff coming in our countries of intervention in the coming weeks.
Great,
the last thing I would be remiss if I didn't mention the supply chain on the testing supplies. Yeah. It's I mean, you see numbers go up, you see day on day increased numbers diagnosed, and then boom, the numbers drop off, and you can tell when the lab has run out of reagents, or they've run out of swabs, or whatever, and it's really going to get in if that supply chain doesn't free up, we're just going to be dealing with a mess.
What about personal protective equipment? Is that available? Is the supply chain impacted there? Can those be manufactured in Africa at all? Where do they come from?
I think that there's going to end up being kind of a mixed supply chain there, because yes, of course, there are a number of things that can be manufactured locally. There are things that people don't want to mess around with are the N95 or the FFP2 masks that are absolutely crucial for healthcare providers to protect themselves from exposure. But I think that as far as surgical masks go, and all of the the bonnets and lab coats, those are being produced locally. Now, Nico, is there any news on the local production front of protective equipment?
No, we designed and with the help also of WHO and others, we designed the model to product them. And now these are going to be used by the staff, ALIMA staff, that are not working in frontline, but for the medical health worker managing COVID cases. They definitely need the FFP2 or the surgical mask that are in line with the norms, and for this we would have to supply internationally. I mean.
Great. Nicola, I'd actually be curious on a personal note. You've been involved in the Ebola crisis. You too, Suzanne. How does it feel different, or does it feel similar on the ground, and both on the ground on the day-to-day, and in terms of where it's heading, right? It's bigger in some ways, it's impacting the whole world. Maybe it's not quite as horrific on the day-to-day where it is happening. I'm very curious, just your own personal impressions of how the two incidents differ.
Well, the first that I have in mind is the difference of the international supports, because the Ebola outbreak between 2014 to 2016 in West Africa was only for 4 countries. And the most recent, or the current one in North Kivu, is only one area in one country. And we saw there, especially in North Kivu, a very massive international support from WHO and other medical agencies in the world. But here, since all countries are affected, every country is by its own. And in most of the coordination meeting where we are working in the countries, we can count the medical international organization like 1, 2, or 3 people at max. And I'm not sure most of the countries around here were expecting such a kind of isolation in terms of response, and that would be the biggest difference for me.
It's a little ironic, isn't it? Because this is an epidemic that is impacting the whole world. We all can identify much more with COVID-19 than we could with Ebola, because we are seeing it in our own countries. And yet, because it is impacting our own countries, everybody's a little bit concerned about their own backyard, and there's less attention on the crisis that is evolving in Africa, in some of the most vulnerable countries. Susan, I'd love your thoughts a little bit on who in those countries is specifically vulnerable. I think in some senses, the countries are lucky to be very young in terms of population, but there are also some specific challenges, right? I'd love your thoughts there.
Sure, I'll take that in a second, but before I want to be, just to comment on the ways that this is same or different compared to Ebola. The one thing that is really, I think, beneficial and terrific is the degree of sharing within the medical community. The ways I have never seen so much information, put out. Some in terms of hydroxychloroquine, it was kind of I would say, an overall negative. But there's been so many other examples of people sharing their learning in real time, and that so one of my main jobs is try to stay abreast of what's going on and try to help pass on to our teams in the field the things that they can use, and so that we can adapt and benefit from other people's learnings. It's certain that the epidemic in sub-Saharan Africa is going to play out a little bit differently because the population structure is substantially different, right? 50% of the population is under 15 years of age. And so contrast that to Europe, where 22% of the population in Italy was over 65, I think, which is one of the reasons why they had they were hit so hard. So thus far, we have not seen any significant illness in children, but I suspect that just because there are so many children, we will eventually start to see some COVID cases in young children. The people who are becoming significantly ill are still very similar in profile to what's being reported in Europe and North America. So of the people who have died, almost virtually all of them are over age 50. Most of them also have coexisting conditions like hypertension or diabetes. And of course, the other thing that we don't know how it will impact are high rates of malnutrition that we see in sub-Saharan Africa, and whether these kids are going to be more susceptible to illness than well-nourished kids. And the other major health issue that we have in sub-Saharan Africa is a very high prevalence of sickle cell anemia. And so this is also a disease that may end up constituting a risk factor for severe disease or complications. So I'm sure that our experience, we are gearing up to carefully document the cases that we treat along the lines of what everybody else has been doing, try to share as soon as we can the learnings that we gain from the patients that we're treating. Micro.
Sorry. Do we have much evidence yet on the way that prevalence of HIV or TB may impact the population impact of COVID-19?
All I know is what I've been watching from South Africa, right? And it does not seem to date that people who are living with HIV are at a higher risk for contracting severe COVID disease at this point. I think that for tuberculosis, it's probably another, it's not quite as, it's more serious. And again, the thing that you would really worry about for people under TB treatment is this capacity to maintain the functioning of the health system so that they continue to receive their medicines and their ongoing care. Out of all these crises, there are always a silver lining. Out of the Ebola crisis in 2014, 2015, we finally managed to make laboratory services a kind of a standard of treatment. We were able to introduce this into our normal hospital programs. And now with this crisis, we are going to get better infectious disease diagnostics for sure, because for the foreseeable future, until there's a vaccine, every single person with a runny nose and a cough, we're going to sit there. Is it flu? Is it COVID? Is it and TB? And in order to treat the patient properly and in order to protect the community, we're going to need to get an answer to that question. And so I'm quite confident that we'll get better diagnostics out of this.
Do you have a sense of how we manage this in the long term? I think one of the things that we are all afraid of is this coming back again and again. And I think that one of the things that we in the public health community know very well is that you cannot eradicate the disease in America and Europe and then say the job is done. If it continues to exist in Africa or Asia or other places, it will come back. How do we continue to manage this? How do we continue the attention once the first wave has passed?
Well, I think that it's going to be, test, isolate, treat, or test, treat, isolate. And so that just brings me back to the, when you're in, as a general pediatrician working in a clinic, and I see a 1-year-old with a fever, a runny nose, and a cough, I might do a swab, and I, would first test for RSV because that's the most likely pathogen. And if that's negative, then I might go on to test for, influenza A or B, and then, work my way through that way. And I'm sure that the same sort of thing is going to develop in the projects where we work, because that's the only, it's the only reasonable, responsible thing to do. I mean, for the longest time, I've been working in sub-Saharan Africa for 15 years now. And, the most glaring deficiency is our inability to provide precise diagnosis. The reason why we classify everything as, respiratory, you die of, pneumonia, diarrhea, or malaria, it's because basically these are the only 3 categories we, give ourselves. And if we advance along the, capacity to provide, point of care accurate diagnostics, then we'll have a much better idea of what we're actually treating, and we'll be in a much better position to stop outbreaks before they occur.
Are you optimistic about our ability to develop a cheap, effective, widely scalable test for COVID-19?
I'm not sure that I have the scientific background to have a well-founded opinion, but I certainly know that our colleagues at the Institut Pasteur in Dakar are hard at work to develop a point-of-care rapid test along the lines of, if we can do it for RSV and influenza, is the reason why we can't do it for SARS-CoV-2, when the consequences of not doing it are going to be exceedingly expensive and dire.
Right. Nicola, I'm interested in your perspective, moving between Europe and Africa. What are some of the misconceptions that you think people have about the way that Africa is able to tackle this disease and other health priorities?
It's a difficult question. I think everybody is well aware of the COVID-19 in the countries, because it's everywhere in the world. And if we compare again with Ebola, where it was only in a very located area, and now we cannot say that the disease doesn't exist actually. We heard a lot of rumors saying that maybe the heat or the humidity or the color of the skin would prevent the outbreak to come, but there are actually no reason showing that the outbreak would not be there in African countries. And I think what we are all expecting is this time where the number of new confirmed cases will increase very quickly. And the biggest difference we see is that instead of 4 weeks, we might have 8 to 12 weeks before this. So I think we are still in this, and when I say we, I say the people around, and maybe it's a misconception from me, but anyway, I think we are waiting for this time, and all wondering, okay, is it going to happen in Africa? But there is no reason that is not going to happen, and that is the message that we are trying to share, and to be sure that all the hospitals where we are working in or around us are preparing for this. And then they would be ready when it would come. I think it's also why most of the countries here took this distanciation measure very early. If we compare with other countries in northern countries, after maybe the 10th confirmed cases, they decided to shut down the borders and to put in place kind of quarantine. So they are very well aware of this, and just waiting to see when.
Yeah. Can you tell us a little bit, I think recently an experienced ED physician committed suicide here in the US because of the stress of dealing with all the deaths that she's seeing around her for COVID-19. And here in New York at 7 p.m. every day, there's the clap to honor the frontline workers. who are really in such a difficult place and are often afraid for their lives and the lives of their family at home. Can you tell us a little bit, maybe both of you, about how our frontline workers are, how are they feeling? How are they dealing with the fear of dealing with something like that, and gearing up for a response that is difficult in all situations, let alone in a place like, in places that are not necessarily as equipped as they would like to be?
Yeah, I mean, myself, my colleagues may have, more so than clinicians in North America, have experience of response to epidemics. So we have, experience of, cholera outbreaks and just 150 people waiting to be seen. So the confronting the enormity of the need may not be quite so foreign to to our colleagues, but that is in no way to minimize the stress of working either in Ebola, working continually confronted with a pathogen that kills a large proportion of your patients and that threatens you every single day. We included immediately psychological support to staff members in our Ebola treatment projects, and we do exactly the same here. It's maybe different, slightly different types of stress. Again, the fact that it's everywhere, and you feel like you can't you can't touch anything, you can't live normally. You're afraid to go home, you're afraid to take it home to your family. It's far more transmissible than Ebola is.
Right.
So so I think that the outstanding, the unique feature of this is going to be the extent to which to how many people are actually affected by it, because that's, I mean, we were just looking at some modeling for Niger and Nigeria, and the numbers that came out of the London School are just like it's mind blowing. Like, oh my God, how are we gonna have to deal with that? And it's just a model, so we don't know. But it certainly is a wake-up call for what we're going to have to, prepare ourselves for.
Yeah, yeah. Excellent. Nicolas, do you want to add anything to that?
Yeah, it reminds me the 2 first weeks in Ouaga or in Conakry, and when we arrived, obviously the health workers were the first affected because they are in contact with confirmed cases, and then they get infected, and at one point, none of them wanted to go and to see the patients because they had no adequate protective equipment, and they were not really trained, or the health worker that we found in the hospital were not especially used to manage this kind of patient and outbreak. And we are seeing days after days that if we bring the adequate protective equipment, and if we are working together on the protocols and on training, the confidence is also increasing, and now they can provide better care to the patients. But we're still working on a way to provide them with more comfortable comfort or support, like trying to find a space where they could stay, they could sleep actually close to the hospital, and not going back to home for those who would not want to contaminate, or who would fear to contaminate their family. And as Susan said a lot, we are also trying to push to make the testing almost systematically for all the health workers that are working in the COVID facilities. Well, I don't want to go further because Susan is there. Maybe you want to add something about that, but that's really something that we are pushing for.
Yes, if I could say the word test again, to systematically test the people. Yeah, we need to systematically test the people who are working in the units. I mean, it's only fair to them. It's only fair to patients to minimize nosocomial spread. And so this is where I certainly plan on concentrating my efforts for the next few weeks.
Right. When I read some of the accounts of health workers here in New York, one of the things that is very striking is just how helpless they often feel. And really what is most devastating, I think, is that sense of helplessness. And I think that is why the Oxygen for Africa is so meaningful, because I think that there's nothing harder than being a doctor or being the frontline worker, seeing sick people and not being able to help. And one of the only things that can really help in this situation is the availability of oxygen. And I think on that note, the message of Oxygen for Africa is so important, because it is the one thing that we as individuals, as donors, as community can really do to provide that minimal basic support that we all take for granted here. You go to a hospital, you go in an operation, and there's any condition, you know that oxygen will be pumped to your bedside. And in Africa, that very simple, very relatively cheap intervention is really what will save lives, as well as enable those workers to do their job. Because being able to just sit there knowing that you could save somebody's life, but not having the simple oxygen to support them must feel very discouraging and very difficult to deal with.
Yes, and I mean, I've taken back to my first assignment in Uganda, and I was on a pediatric ward with a child who was receiving oxygen from the only tank that we had, and there was somebody who ran over from the maternity ward to beg me to give them the oxygen tank for a mother, and I was, you know, to be put in the position to have to decide, you know, who gets the oxygen is just.
I cannot even imagine. On that note, I wanted to thank you both and thank all the frontline workers who are risking their lives and helping people in these really difficult situations. I also wanted to thank our donors, the Gates Foundation, the Skoll Foundation, Resolve to Save Lives, who really enable us to do this work, and all the individuals who are supporting ALIMA's work, ALIMA USA's ability to support ALIMA. So thank you very much. If you have any last message to anyone watching, please share now.
Thank you very much for joining us. And please feel free to contact with any further questions and help us provide oxygen to COVID patients who need it. Thank you.
Yeah, wouldn't say better. Thank you, everyone.
Well, thank you everybody for joining. There are a couple of outstanding questions. We will answer them separately on text, and this recording will be available. Please share it widely so people see the importance of this work, the importance of oxygen, and what we all can do to support the people who are there in body and spirit fighting the good fight. Thank you, everyone. We really appreciate your work.
Bonsoir.
Thank you.
Bye-bye.
Bye-bye.